Uh, today, uh, Today we will have a longish discussion on carcinoma rectum. The case will be presented by Dr. Malavika Rao, who is a third-year junior resident at Apollo Clinical Hospital, Calcutta. And today session moderated by Professor Chintamani, who has joined us kindly from US. He is in his trip to US. So Dr. Chintamani is very clearly seen and audible. We have no problem. So Malavika, you can share your screen and start presenting. And at the end of history, let up some discussion on history part and then examination and then rest of the discussion.
Sure. Yes, sir. Milind, can you please share the slides? This is a case presentation of carcinoma rectum. My patient, Mr. Mandal, is a 60-year-old male who's a clerk by occupation in a residence. He presented with the chief complaints of bleeding per rectum for the past 4 months and altered bowel habits for the past 3 months. He was apparently well 4 months ago when he had an insidious onset of painless bleeding per rectum for the past 4 months, which is small in volume and presented as bright red fresh bleeding, which is seen in the toilet bowl. He also had subsequently he had altered bowel habits, which has been there for the past 3 months. Earlier, 3 months before 3 months ago, he used to pass stool once a month, which was his regular bowel habit, and now it has increased in frequency. And he's now defecating approximately 3 to 4 times per day, and often has to strain, but is unable to pass stool while straining. It's also associated with passage of blood and mucus rectally. There is no history of any mass protruding from the anus, pain in and around the anus, melena, abdominal pain, distension, fever or loose stools, no urinary tract symptoms, and no symptoms suggestive of distant metastasis like unintended weight loss, anorexia, jaundice, cough, or lower back pain. Past history, there's no history of similar complaints in the past. He has no known medical comorbidities. He has had a laparoscopic cholecystectomy in 2009. Personal history, his bowel habits are altered as mentioned. There are no alterations in the bladder habits. He's a cigarette smoker and consumes around 1 pack per day for the past 40 years. His history of occasional alcohol consumption for the past 40 years, approximately 30 to 60 ml once every 3 to 4 weeks. He has no known drug allergies. He is a non-vegetarian and a heavy consumer of red meat. And he's not on any antiplatelets or NSAIDs. In family history, there's no history of any colorectal, breast, or pancreatic malignancy, and no cancer-related deaths in any first-degree relatives. In summary, this is a 60-year-old gentleman who presented with complaints of fresh, painless bleeding per rectum for the past 4 months, with a small amount, which is small in amount, which is not associated with the passage of stool. He also had increased frequency of passage of stool with unfruitful straining and passage of blood and mucus per rectally for the past 3 months. There is no history suggestive of distant metastasis. He has had a laparoscopic cholecystectomy. He's a chronic smoker and has occasional alcohol consumption, and his family history is non-contributory.
Malvika, that's a good history. Would you like to elaborate more on the altered bowel habits? Because I actually could not understand much, whether it was constipation or diarrhea or both, or it was spurious diarrhea or anything else you would like to say about the altered bowel habits?
Yes, sir. So 3 months ago, he used to, for his life, he's been having approximately one episode of stool per day. But in the past 3 months, he's been passing a more amount of formed stool in the day. But a lot of times he has to use the washroom. He strains and has a little bit of pain, but he's unable to pass stool. And the pain is relieved on passing mucus and blood, which is tenesmus.
Yeah, so that's a standard term. Therefore, I was waiting to hear if you would say there is a history of tenesmus, so that the examiner is inclined to ask you what is tenesmus, number one. Is there any spurious diarrhea?
Not that he is mentioned.
No, but you just mentioned patient has to go more frequently. But all that he passes is mucus and blood. So that would be spurious only, because why should he have, he's passing formed stools, and in between he has this phase when he has tenesmus, which will again define for us. And secondly, what do you understand by the term spurious diarrhea?
Spurious diarrhea is when there is a constricting lesion in the rectus, in the rectum or sigmoid, there will be distal impaction of stool, which over time there is bacterial degradation, and it becomes liquefied and passes out as a mucus or something like diarrhea, which is false diarrhea.
I agree. That's correct. You answered it correctly. So, how is it different from the history you've given us?
So
What is he
usually
passing when he stains finally? What is it that he's passing?
he passes a small amount of stool and mucus and blood.
So, won't it be spurious diarrhea? I'm just curious.
Yes, sir.
So, you defined it and you could have used that term. What exactly do you mean by tenesmus?
Tenesmus is when the patient has a feeling of incomplete evacuation, has to go to the washroom multiple times, and is straining but is unable to pass stool. And classically, it's relieved when he passes mucus, or when he is able to pass mucus.
No, tenesmus would be associated with pain also, no?
Pain, yes, sir. Colicky abdominal pain.
So, there is something to do with pain here also, which we cannot ignore, because it's an important part of that, the symptoms that he's presenting. And what is the significance of laparoscopic cholecystectomy in the past? Any significance, or just a coincidence?
So there is a theory that after laparoscopic cholecystectomy, because there is increased bile salts in the colon, which can irritate the colon and cause colorectal malignancies. But
bile is a known carcinogen, actually. So it's not a theory, it's known, but it's more for the colonic malignancy than for rectum. But colorectal exists together. So there is a possibility. And it's not always laparoscopic cholecystectomy. Any cholecystectomy would do that. Open cholecystectomy would also do that. So you can always connect it. And the rest of the history, I thought, was by and large very clear. And you did come out with a very significant family history in the correct way. But you mentioned something in the past history. There's no history of similar complaints in the past. How could he have similar complaints in the past?
As in if he's had bleeding, but I was trying to rule out if he's had
more specific. No, that's what I'm saying. You could be more specific about those points, no? There is no history of any bleeding per rectum in the past, no history of having undergone some kind of hemorrhoidectomy or polypectomy in the past. Then that would make a little sense to anybody, Otherwise, similar complaints are not possible. I mean, otherwise you'd have the same illness in the past. So that's not what he has. Smoking is connected. I agree with you. Rest looked all right. And what is the first symptom that would indicate in a carcinoma rectum that patient has got metastasis to the liver?
Jaundice, sir.
No.
Jaundice is not early, dear.
Okay.
It might be some general symptoms.
I'm asking a very specific question, right? It is not true of only colorectal malignancies, but very specifically for colorectal malignancies. The first symptom that would indicate liver metastasis is loss of appetite, and it can be very severe. But secondly, the history is so obvious that the patient can very clearly say that now my appetite has suddenly gone down. And the first LFT to get deranged is alkaline phosphatase. So these two things you can remember together. Okay. Now we can move to examination, I think, unless Dr. Sahai. Move on. Let's go to the general examination.
On general survey, my patient is conscious, cooperative, and oriented to time, place, and person. His Kanofsky's performance score is 90. His BMI is 22.8. He's well hydrated. Currently, he's apyrexial. His heart rate is 60 beats per minute, a BP of 100 in the right radial artery, which is normal volume, normal pulse, and there's no radial or radiofemoral delay. BP is 110 by 70 beats per minute in the right brachial artery measured in the supine position. His respiratory rate is 14 beats per minute, 14 cycles per minute. He has mild pallor present. There is no icterus, edema, cyanosis, clubbing, or generalized lymphadenopathy. JVP is within normal. On abdominal examination, the abdomen is scaphoid. The scars from previous surgery are healthy. There is no engorged veins or visible peristalsis. Umbilicus is averted and centrally located with normal thoraco-abdominal breathing. There is the abdomen is soft, non-tender, and has no distension. There is no palpable mass or organic cavity. Peristaltic sounds are normal. And the inguinous total region and the external genitalia are clear. On DRE, which was done in the left lateral position, there is a non-tender hard mass right at the tip of the index finger, which is approximately 3 centimeters in size on the posterior lateral wall of the rectum. The sphincter tone is normal. There is also grade 1 prostatomegaly. The rectovesical pouch is normal. Anal canal was normal. And there is blood and mucus soiling on the gloved finger. On proctoscopy, there is an irregular growth approximately 6 centimeters from the anal verge, which is 2 centimeter by 3 centimeter in dimension. There is bleeding from the superficial ulceration over the mass, which had diverted edges, and there are no internal hemorrhoids. Systemic examination was essentially normal. Summary. A 60-year-old gentleman who was otherwise well with Karnofsky's performance score of 90, presented with complaints of insidious onset fresh painless bleeding for rectum for 4 months and altered bowel habits for the past 3 months with increased frequency of defecation and passage of blood and mucus rectally. There is no history suggestive of distant metastasis. And on examination, abdominal examination and the other systemic examination was essentially normal. On DRE, next slide please. On DRE and proctoscopy, there's a 2 by 3 centimeter hard, non-tender ulceroproliferative growth in the mid-rectum, approximately 6 centimeters from the anal verge, along the posterolateral wall of the rectum, with blood and mucus staining in the rectum, and grade 1 prostatomegaly. My provisional diagnosis is an ulceroproliferative growth in the mid-rectum, which is likely of malignant etiology without any features of distant metastasis in a 60-year-old male without any comorbidities.
Could you go above the growth?
Yes, sir. I could go above the growth, which is all around. It had irregular margins and was irregular surface and margins.
So it is 6 centimeters from the anal verge.
The distal margin was 6 centimeters from the anal.
All right, I got it. And you were still able to go beyond it. How long is your finger?
So I have a 10 centimeter index finger.
Oh, okay. And I was wondering. So it is quite an effort to go above these growths, because I have not been able to do in many cases. So there is no narrowing or there is no stricture. Patient is symptomatic for features of almost near complete obstruction, as you suggested. So I would be very careful in committing to mid-rectum, 1. And number 2, I'm not too bothered if I can get above it. I'll be happy to just mention that I could feel the distal end was 6 centimeters from the anal verge, which again, 6 centimeters makes it how many inches, by the way?
A little more than 2 inches.
So going beyond, so how far you could go? I'm actually curious.
As I could palpate just beyond the growth, but not much further away.
And what circumference, how much of the circumference you felt was involved?
A little less than 1 quadrant. So it was only along the posterolateral wall from around 5 o'clock to 6 o'clock position.
That makes more sense if you mention the clock, because posterolateral would be more on getting the three-dimensional examination, which you cannot do. So you felt it from 6 o'clock to 9 o'clock position. That's what you're saying?
5 o'clock to 6 o'clock.
5 o'clock to 6 o'clock position.
Yes, sir.
Okay. And did it bleed on touch?
So it was already bleeding, and there was an ulcerative lesion which was already bleeding. So I'm not sure if my touch was causing the bleeding or if it was bleeding spontaneously.
So if it was bleeding, then naturally your touch would only make it more bleeding. I mean, it'll just get
Yes,
worse.
sir.
So that
Yes, sir.
that is fine. But my interest would be in knowing whether it was fixed to the just the rectal wall, or it was, since you're describing 5 o'clock, right? So to be free from sacrum, you need to mention that. For our interest, I can understand that you felt it is mobile, so that is all right. And if you're getting above it, it's a point to be mentioned. And the circumference, how much of it is involved, has something to do with the duration of the illness, you would understand,
Yes.
right?
Yes, sir.
And what circumference is involved in 6 months?
Around 1/4 of the circumference is involved, sir. Every
Very
6
good.
months is 1/4.
So that's what I'm saying. So it makes us understand as to how old is the disease, roughly.
Yes.
And what in addition, suppose you found it was not very freely mobile on the sacral hollow, which you need to describe, as I mentioned. What next? What other examination would become necessary in that case?
We will have to do a lower limb examination as
Excellent.
well as spinal.
Very good. Absolutely. And the patient would have some symptoms of sacral neuralgia or the sciatica, etc., or the related pains. I mean, I would say nerve root pains.
Yes, sir.
That's perfectly okay. And when you're saying 5 o'clock to 6 o'clock, we are talking about a posterior lesion. But suppose you are not able to get above it, although I'm granting you that you could. What can be done to get above this in a patient who's lying in SIMS position when you're examining?
In the SIMS position, we can ask the patient to strain, which will, like if they were passing stool, which will help the mass bring the mass downwards.
When you ask the patient to strain, it will pain, because actually they are having the element of tenesmus, as you mentioned. That is, what is the cause of tenesmus would explain that. It's got something to do with what? Why would the pain happen?
I'm not sure, sir.
There are sphincters and there are other aspects which you need to look into. So you can do some reading about the tenesmus part. I'll not cut on time for that. But importantly, you can do what is called the Valsalva maneuver. You make the patient do Valsalva maneuver, and that is slightly better than making the patient strain, because as they strain, they tend to have more pain. And next was your description of the growth. You mentioned it's a ulcerated,
Yes.
Or was it an ulceronodular kind of a growth? How was it? Can you just, for my understanding, describe it once again?
So I described it as an ulceroproliferative growth. So it was a hard mass.
So it was ulceroproliferative growth. So that takes care of it. And naturally, it was bleeding on touch. And was it, I'm again asking, was it involving the muscles of the rectum, or it was just confined to the mucosa? Clinically, it is difficult, but suppose I was to ask you.
So as far as I could make out, it was mobile. So I don't.
It was free mobile, and you could not comment beyond that. That's perfectly all right. No problem with that. Now, when you mentioned about examination of the abdomen, can you go back to that slide? Because I noticed something which I'm not able to recall quickly. There is no, you have not put the picture here, but even in the previous case presentation, it so happened it was cancer stomach, I think. Scaphoid abdomen is not something you need to lose your sleep over. You, as long as you mention not distended, we are happy because scaphoid abdomens are not seen. And the important thing was that there was no organomegaly and there was no free fluid. These two things matter to us more than anything else,
Yes.
right? And there was no hepatomegaly, as you clearly mentioned in your presentation. I don't know, because usually what can go wrong in a rectal examination is nobody's going to cross check for the good of the patient. So whatever you say would be the findings, and usually these cases may not be provided to you unless the findings are provided, because it can be cruel on the patient if more than one candidate is examining. But I think it's a very good idea to cover this part also, because very often it's mostly a theoretical discussion. That's why I'm spending a little time on the examination of the case, because
Okay, sir.
what exactly is Sim's position?
Since position, the patient is in left lateral position with the left leg extended and the right leg which flexed at the knee and the hip joint uh, in order to give us access to the rectum.
Well, that's a very common position in which you start your career as a medical student. You know that second year medical student, and that is so often described wrongly. You did exactly the same thing, so don't mind it. It's a common thing. That's why I thought I'll ask a simple question. Patient is left lateral after you explained everything to the patient as to what are you going to do. So a good consent becomes very important. And then you can flex both hips or you can flex one hip. It's optional. And if you have to flex one hip, which one you would keep extended?
I will keep the lower leg extended. So if on the left lateral position, the left leg will be extended.
So the trouble is patient keeps toppling over. So a lot of people like to flex both the hips. That is what was done in original Sims position. And that again is not complete. Patient has been explained that we are going to examine you from the lower end after excluding any painful spot or any spasm, and we won't hurt you. We will use a good amount of jelly to lubricate and plus give local anesthesia. And in case you have any pain or discomfort, please let us know. The second part is always cover the genitalia, because they don't need to be exposed to embarrass the patient. That's one thing which you can often ignore. Now, the hips are flexed, and the other thing is the buttocks are jetting out of the bed, the couch. They are not on
Yes,
the couch. Otherwise, you'll have to go over the couch. No, you'll have to
yes, sir.
go all the way over. So they are jetting out, and it is advised to put a little pillow under the buttocks to lift it up so that you don't have to bend down so much. Now, don't you realize it's such a cumbersome thing to do? But if you make it a habit, it's not impossible to do. At least, even if you don't want to put a pillow, I've told you the exact copybook positioning of Sims,
Okay.
which may not be always the possibility, but yes, flexing the hip and getting the buttocks jetting out of the edge of the examining couch, so that
Everything.
patient is actually in the same axis as your eyes, and you're able to see it straight rather than going across over and then trying to see straight up. Exclude a hip fissure, exclude an external hemorrhoid, exclude any lesion outside which can cause pain, and do exclude on DRE first, gentle DRE, after lubrication, that you don't inject your gel in the wrong place. So you need to first of all find that slot. That nozzle is not a very comfortable thing to push in. So
Yes,
first,
sir.
again, finger is softer, but use the little finger to feel that there is no acute spasm. Then you ask the patient to take deep breaths so that the lower end can be relaxing. And it's only after some time of putting the jelly that you should actually do the examination. All this does not happen. Therefore, you don't remember. So try to do it at least 50% of this. It will make your examination better.
Okay,
Now,
sir.
is there any need to do proctoscopy in addition to DRE in this patient?
Yes, so since it's a rectal, we can clearly feel a rectal marks. It is very important to a proctoscopy to define the tumor and specifically the tumor height, which is most accurate on proctoscopic examination as opposed to other tests that are available.
Yeah, not tumor height. The distance of tumor from the anal verge. It's not vertical, so there is no height here. But proctoscopy is recommended only in patients who don't have pain or discomfort, because very often you may not be able to do it as a part of your examination. But if it can
Yes.
be done, it is okay. That is all right. So you've done the examination, you've looked for what else do you need to look for in the abdomen, which again we don't find in your description. Is it important to examine the inguinal lymph nodes?
Yes, sir, it's important because if there is invasion in the lower part of the rectum, will drain into the inguinal lymph nodes, and the upper part drains into the iliac lymph nodes. So it's important to mention, try to examine the iliac nodes. Inguinal nodes are more superficial, so are more easily palpable.
See, you've covered two things in one, which can sometimes go wrong. You see, these days we don't call them cancers of the rectum. We call them cancers of the anorectum. The whole region is defined as one, because earlier you were relying on lesions above the dentate line and those below the dentate line. And this is such a faint difference. We know that below the dentate line, you have stratified squamous epithelium, you have, the somatic innervation, your blood supply is not, it is also somatic, not portal, it is systemic, right? And you
Yes,
know
sir.
the lymphatics go to the inguinal nodes, not iliac. Iliac are a retrograde fling from the, from the pararectal nodes going upwards from towards the aorta. So inguinal lymph nodes are easily felt, and also the iliac nodes can be palpated. And when iliac nodes get involved, we know the stage changes to something drastically.
Yes.
Uh, it's a late disease, which is cancer rectum. But in the case of the squamous epithelium or the squamous cell carcinoma, they can actually be enlarged subsequent to enlargement of the inguinal nodes. So the journey, the route is important. So you need to describe no lymphadenopathy and no free fluid and no organomegaly. All three get covered in one go. I just
Okay,
wanted
sir.
to spend some time on the clinical examination part. The rest becomes a very straightforward theoretical discussion. Okay, so
Okay, sir.
your diagnosis is carcinoma of the rectum. Why is it not a benign lesion?
So firstly, the age, it's 60 years. On history, the age of the patient is 60 years, which is approximately the peak time for carcinoma rectum. Secondly, he's having bleeding per rectum and tenesmus, which is suggestive of a malignant etiology. He also is a known smoker, consumer of red meat, and all of these points on history support my diagnosis. On examination, it's an ulceroproliferative growth, which has everted edge. The ulcer has everted edges, and there is bleeding, which is which is very strongly suggestive of a malignant etiology as opposed to a benign etiology.
So that's history. Let's move to examination. You can now utilize all those features. There is history of tenesmus, spurious diarrhea, and there is a term called feeling of incomplete evacuation, which is very suggestive of cancer rectum. No? Am I
Yes, sir.
audible? Yeah.
Yes, sir.
So you can utilize all those three heavy sounding terms to support your diagnosis in history. And on examination,
The ulcer proliferative growth, which had everted edges and is bleeding, which is unlikely there is going to be a benign etiology.
oh, I see. Uh, so if it is a benign, that is, if I say it's a benign lesion, what is the likely benign lesion that can happen? Of course, when you're saying everted everted edges, ulceroproliferative growth, which is bleeding, it is going towards malignancy. But is it any other? Is there a possibility of a small lesion which is only ulcerative being found in the rectum?
Uh, which is benign.
Yeah.
Yeah.
A
Sorry,
solitary rectal ulcer syndrome.
Okay. Good. You're a smart student. So Therefore, I deliberately asked this question so that I can justify giving you more marks than I would have given you otherwise. So do understand the way the examiner also thinks. So
Yes,
I
sir.
just wanted to explore it out of your mind, and don't be surprised if uh, you can find one odd case in your lifetime. But I'll call it malignant unless proven otherwise. So there's no problem
Okay.
with what you said. But be prepared to be flexible. That's why I was
Okay, sir.
asking you.
Yes, sir.
Now you got the disease, you got the diagnosis, and you got some insight into the patient's journal profile as well. In your journal
Sir,
examination,
I think, sir, she should mention about a benign lesion, which is villus adenoma in the rectum,
yeah,
which
yeah,
may present with
Let's
mucus,
add more.
bleeding, and you find a proliferative mass. So that is another important benign lesion in the rectum.
Yes.
absolutely, sir. Yeah. Hello? Yeah,
Uh,
I didn't hear that. So, can you repeat that? Your signal was
I didn't
not
say
good or
anything,
mine?
sir.
Yeah.
No, sir. I didn't say anything. I think there's background noise from someone else's.
Oh, okay. So, and the other thing, I actually was very happy the way you covered most of the things. But remember, if you're flexible and if you're relaxed like you were, you can think of many more things. And don't be totally rigid about one diagnosis which you brought from home and you want to talk about it. People want to talk around it mostly. There was one more thing that was coming to my mind. It just slipped off. If I remember, I'll get back on that. So your diagnosis, as you're thinking of it to be a malignant lesion involving the rectum. What is it likely to be? Carcinoma of the rectum. That's what you said.
Yes.
Am I right?
Yes.
And what would be your clinical stage?
My clinical stage will be a
Can you make
T2.
a stage out of
No, no,
your
no.
visual examination?
No,
Oh,
sir. We need
let
radiological examination to confirm to
yeah. So
accurately
that's why
stage.
the question. That's why the question, dear. So don't make a clinical diagnosis in rectum unless you've done imaging. Now you need to, therefore, when you're asked a question, you should be clear in answering it. You are not going to comment on even the T stage will be wrong. You know that
Okay.
the
Yes, sir.
sensitivity of clinical examination is naturally extremely poor in these cases.
Yes, sir.
How do you proceed now?
Sir, I'd like to run some tests to confirm my diagnosis and confirm and support my diagnosis, to stage the disease, and certain general tests. To confirm my diagnosis, I would like to do a colonoscopy and a biopsy from the ulcerative mass.
Yeah, I have to stop you because you should be very frank and honest in what you're doing, what you're speaking. It should be what you do every day. Do you start with colonoscopy if the patient comes to you in your OPD tomorrow?
No, sir. I would first advise general blood investigations, get a imaging done, and
No, no,
then
no, no,
ask for a.
no, no, no. Don't go to the other extreme now. I'm asking you a very simple question. You are sitting in the surgery OPD. This patient has come to you. I think there is some disturbance or your signal is wrong. Can you hear me?
I can hear you, sir.
Yes, sir. We can hear you, sir. Some other.
Okay. Yeah. Now, I mean, most of us, what do? We have done proctoscopy. There is a lesion in front.
Yes, sir.
Can you take a biopsy while doing
Yeah.
proctoscopy?
Okay. Yes, sir. We can take a biopsy if it's
That
available.
gives a
No.
good.
No. Scan is a very,
Will,
very
will.
difficult thing. Because your answer was, I'll do colonoscopy, biopsy. Can you put in a scope into a patient where you have not even done a biopsy? I mean, it's not done that way, no? You know it. So we'll do investigations to confirm the diagnosis, to support the diagnosis, to stage the disease, and to treat the patient. To confirm the diagnosis, naturally, you would like to take a biopsy. And you must have done rectal biopsies. It's not something new. All of us do the same thing. Most of us practice that way. So you will take a biopsy and it comes out to be a squamous cell carcinoma. Now what do you do?
So I'll have to get a
Will you do a
colonoscopy to see it.
colonoscopy now? No, no, wait a minute. Let me finish my second part of the question.
Okay.
Would you do the colonoscopy now?
Yes, I want to see if there is any synchronous lesions in the rest of the colon.
It is a squamous cell carcinoma. What synchronous lesion of squamous cell carcinoma will occur in the colon? What is the lining in colon? It's columnar epithelium. You can't get squamous cell carcinoma there. So now the scope has no role. You're going for imaging now. So please, therefore, do not use those, just like it is adenocarcinoma, you decided. So you need to first of all know whether it's adenoma carcinoma, squamous cell carcinoma, or adenosquamous carcinoma. These are the three possibilities. Or it can even be like the villous adenoma that was mentioned. It could be even a benign lesion like something which is inflammatory. Even tuberculosis has been defined in some situations. So you don't know really. So we need to first establish the histology, right?
Okay.
Once you got the histology, accordingly you will plan your further investigations. If it is an adenocarcinoma, I agree with you. We'd like to do the colonoscopy to rule out any synchronous lesions or coexisting polyps or coexisting pathologies of any kind that can happen. And if it is a squamous cell carcinoma, what next would you do? Imaging naturally. Yes or no?
Yes, sir.
The whole management approach changes if it is a squamous cell carcinoma. So therefore, be careful. I deliberately twisted it to that direction. So you've done the biopsy, it's an adenocarcinoma. What all information do you want from the pathologist in your biopsy?
I would like to know the grade of the tumor. I would like to know if there's any perineural or the type of the tumor, Yes, sir. Type of the tumor, the grade of the tumor, if there is any perineural or perivascular invasion.
Yeah, I'm still waiting. Not over. If you're clever, if the pathologist is clever, I don't know about the lymphovascular invasion, how well they tell you, but they can pick up microsatellites, instability, etc. in addition, and there are certain other aspects that they can report. I'm not talking about the gene assay, etc., but at least the type of the pathology and the grade of the tumor can be, conveyed. Now, once you've found out, I think you're walking. If you can settle down at one place, that'll help. Now, if once you've done this, it's an adenocarcinoma moderately differentiated. What next would you do? What imaging?
I would like to do an MRI of the pelvis and the abdomen to see the anatomy, to see the extension into the perirectal tissues, and if there is any lymph node involvement.
You finish with whatever you have to do. I'm not stopping you. Please finish with your answer.
MR, what else?
Okay, sir. Additionally, I would like to get a CT scan of the abdomen, thorax and abdomen to see if there are any metastasis. If not, if it's available in my, since it's available in my institute, I can also get a PET scan to check for any distant metastasis. And yes, sir.
CT
PET scan.
I'm sorry, I couldn't understand, sir.
Okay, let's sir ask.
Now, is PET scan a part of your routine algorithm?
No, sir, but since it's available in my facility, if I want to look for distant metastasis with one single investigation.
Let's talk science, no? Is it indicated just because you have it available? Would you do it? Is it required? What purpose would it serve?
To check for any distant metastasis in their body,
basically
or
for
if there any
metastatic
contiguous.
work. Basically for metastatic workup. You have to listen. Sir. Okay. And why do you want a CT thorax?
So the upper rectal regions usually metastasize to the lungs. So I would like to see if there is any lung metastasis.
But you said it's a lower middle rectum.
It's yes, sir. Yes, sir.
You said so, I thought.
Yes, sir. But it can also, even lower rectal malignancies can also metastasize to the lungs, but more commonly to the liver.
Now let's talk science. Now let's talk about what is done usually. MRI is very good to get an anatomical T-stage description, which is useful. You would like to know whether for the mesorectal involvement and the circumferential margins, etc. MRI is good, definitely. You want to get a good T stage, right? For N stage,
Yes.
some people feel contrast and CT scan is superior to MRI. Although if you have to do one investigation, MRI can take care of lymph nodes also. For M stage, you can do PET in select situations, and especially if the patient is being put on neoadjuvant chemoradiation. For assessing response, it is a good idea. Otherwise, it's not a standard of care and it's not a routine recommendation. That's why Professor Shah was trying to ask you that question. CT
Okay.
thorax can be done, especially if the grade is bad, or otherwise for a metastatic workup, people can do it as a routine. You'll be surprised. Some people recommend that you do X-ray chest, good digital X-ray chest, and then follow it up. Although I don't think X-ray chest is ever a metastatic part of working. Now, about the blood investigations, what would you like to do?
Specifically for this case, I would like to get a CEA, serum CEA level, which will assess the tumor burden at the current time of disease, and will also help me to follow up the patient after treatment to see if there's any recurrence. And routine blood investigations to prepare the patient, to assess the general condition of the patient, as well as if I'm planning on surgery, to assess surgery.
So basically, blood would be primarily for the journal, the journal or the routine investigation, blood, this level of proteins, etc. In addition to that, you have LFT is very important, which you
LFT.
probably skipped. And CEA as a baseline is important as a baseline because it's not diagnostic, but can be useful for prognostic purposes, because there are many benign reasons for CEA to rise. So you need to be careful about using it. But baseline is important. And if you were to plan, because we are short on time, you'll be keeping focused on what is required essentially. Now, if you were to sum it up, I think the investigations to confirm the diagnosis, that is the biopsy done properly under good sedation or good local anesthesia. You can take a good chunk of the tissue. Secondly, once you got the biopsy proven, you get all those features which we talked about. Then imaging can be MRI, and contrast and CT scan is complementary. But for T stage, MRI is definitely superior. But node stages, some people feel that contrast and CT is better. And for metastatic workup, you can do CT thorax abdomen is done anyway. Ultrasound is a part of clinical routine examination. Some people like to do endoscopic ultrasound, the transrectal ultrasound as they call it, for looking at the extent of the disease in the circumferential manner, for getting a clearance when you're resecting it. And the rest you mostly would be a practice of a particular place in the form of PETs, if you're following the PET racist criteria for assessing response. But most people rely on MRI for response assessment in rectal cancer. Now, with your patients, this condition, and suppose there are no nodes and there is no liver metastasis, you've done colonoscopy, there are no synchronous lesions, and there are not even any polyps. Suppose there are any polyps, would that change your management?
So you will have to go for a polypectomy as well, along with it. If you can do the polypectomy, if endoscopically, that would also be we can do it endoscopically and get a biopsy. If the biopsy comes out to be malignant, if there is any malignant tissue, malignant disease in the polyps, then we will have to go for surgery that is involving the rectum as well as the regions that have the
polyps. So your answer could have been more organized in the form that it depends on the polyp, the type of it, and if it is a sessile polyp with induration, or there are multiple polyps where there's a high suspicion of it being malignant, you can plan and discuss it with with the patient. In the MDT, you will discuss as to what should be done. The treatment has to be planned accordingly. You would not like to get surprised later on that you missed out on another pathology in the proximal part of the colon. So your answer could have been more clear that way. And then once the histopathology proves them to be benign, you are comfortable, you can go ahead with the procedure that you thought. And if it is suspicious or involved, then planning could change completely. You may have to resort to some kind of a collection. Yeah, so you will be planning it accordingly. Now, suppose this is a pure rectal adenocarcinoma, which is moderately differentiated in a 60-year gentleman. It's about 6 centimeters from the anal verge, right? And MRI is suggestive of no involved. The mesorectum is all free. There are no lymph nodes. What is the plan?
So in such cases, for a 2 centimeter growth, which is moderately differentiated. Since it is moderately differentiated, there is still a chance of metastasis. So I'd like to go for a low anterior resection, as opposed to a local resection of the tumor.
You mean upfront surgery?
And
you want to go
yes,
for
sir,
upfront surgery?
because there is risk of metastasis. Yes. With neoadjuvant.
The sir has given a scenario. It's a early lesion without lymph involvement, no distant metastasis. So now you have the options. You have to choose between neoadjuvant, then surgery, and then continue the adjuvant or upfront surgery. So there are points in and against. So you just say, you are saying the right answer also. Just clear. You want to go for upfront surgery.
I would like to go for upfront surgery. There have been trials that suggest that you can give neoadjuvant chemotherapy, but there is no significant difference in the disease-free survival or the recurrence rates. So an upfront surgery, which is curative low anterior resection with total mesorectal resection, total mesorectal.
He has given you a very good hint. Now, what is the whole purpose of neoadjuvant chemotherapy? Is actually, it's mostly chemoradiation. That's what we will offer.
Yes.
So what is the basic reason? The sphincter preservation. If you can preserve the sphincter by upfront surgery also, there's no advantage of giving chemo before or after. The same sequencing doesn't make the change, It just facilitates your sphincter preservation. So do you think in this patient, you can preserve the sphincter if it is 6 centimeters from the anal verge?
Yes, sir, we can.
So,
yes, sir, we can preserve.
So it can be offered, right? The upfront surgery can be offered. That is what he's trying to hear from you. You could be more clear on that, right?
Okay.
And the other thing is you'll discuss in the MDT with patient being there. And you said 2 centimeter distal mark. Am I right?
Yes, sir. You can have a 2 centimeter distal mark, free margin.
Yeah, so, which will be 1 centimeter in the donut. So about that basically would be 1 centimeter margin is what you, and for that you can give 2 centimeter margin is a good idea. All right. Have you, that would be the surgery part of it. When do you feel, based on your investigations and everything that you have done so far, that it may not be possible to preserve the sphincter, and the patient is too keen on it and you want to offer it to the patient?
I'm sorry, sir, but it's a little shaky. Can you please repeat the question?
Yeah, I think some sound coming, so maybe you're not able to. I was trying my best.
Yes,
okay, I'll change the question back to the question that we had asked you earlier. What are the indications for neoadjuvant therapy in patients with cancers of the anorectum?
So if there is a locally advanced rectal cancer or anorectal cancer, then we will go for neoadjuvant chemotherapy.
What exactly is locally advanced?
If there is invasion of the pericolorectal fat tissue, or if there's breach of the serosa, and if there is involvement of the any regional lymph nodes are involved, which is N 2 stage, which is 1 to 2 or 1 to 3 or regional lymph nodes that are involved.
So for that, you need to describe it in the form of TNM staging, no? Based on TNM,
Yes.
you would
Yes,
call
sir.
it, right? Not by
Yes.
subjective assessment. So one
Yes, sir.
indication is locally advanced disease. Second is patient's got early disease, but it's closer to where the sphincter is,
Sphincters.
right? So you
Yes,
want to still preserve it. So the whole idea is to preserve the sphincter. In that case, you can put the patient on
Give
neoadjuvant.
Yes.
What neoadjuvant chemotherapy is given to these patients?
So we give chemo radiation is given with chemotherapy can be given with either FOLFOX regimen or Capox regimen or FOLFIRINOX regimen, which is FOLFOX is oxaliplatin, 5-fluorouracil, and leucovorin, and FOLFIRINOX is oxaliplatin, 5-fluorouracil, leucovorin, as well as irinotecan.
Yes, and your patient has the lesion confined to just 1/4 of, or less than 1/4 of the circumference of the rectum. So there's
Yes, sir.
quite a possibility to go up front and still be able to preserve the sphincter. You can go low or even ultra low. What is the difference between low and ultra low?
So the low anterior resection goes up to till 3 centimeters above the dentate line, and ultra low can go up to the dentate line or the levator ani muscle.
I think that's all very nicely answered. Now, in addition to, I mean, we'll not discuss the surgery or the technical details here because it's beyond the scope of a case presentation, especially rectum. One last question, maybe. Suppose this patient had, on imaging, you found out there was a lesion in both segment 5 and segment 8, and let's stick to 2 lesions in that case. Would the approach be different, or you will go ahead with the same plan?
Sir, in such cases, we can do a metastatectomy, or even there are other modalities to deal with liver metastasis, like percutaneous ethanol injection. And
So you were in a tearing hurry to finish up the matter. Now, what has happened to the stage now?
Stage 4 disease?
It's become a metastatic disease, stage 4 disease.
So when it is metastatic, you know, they are divided further in especially colorectal cancers. M is also up to
M1. If there is only one organ involved, is M1A, and if it's more than one organ involved, is M1B.
So it is the M1A you're talking about. So there's no question of upfront surgery anyway. Now, this again becomes a situation where people may try to put the patient on neoadjuvant chemotherapy, which allows you to also assess the response. Sometimes you can check the response. The metastasis can actually disappear and prove it to be a good cancer. And then you have the concept of synchronous or sequential resection. You can do both in one go. You put the patient on neoadjuvant, go for the primary, and then for the metastatectomy at a later stage. So the moment I asked you, you wanted to quickly jump to metastatectomy because this is the only cancer where metastatectomy is done, but that doesn't mean you'll do it immediately. You know that because tumor behavior can be observed by putting the patient on. Would that be called a neoadjuvant? The answer is wrong. It is primary chemotherapy because patient has got a metastatic disease now. So please be clear in your mind as to what the question is asked. Okay.
And colorectal liver metastasis, can you provide cure for this patient? Patient having colorectal liver metastasis. Patient having colorectal liver metastasis, can this patient be offered curative treatment?
Yes, sir. Yes, the patient can be offered curative treatment after primary therapy, or even there is a new technology which is total neoadjuvant therapy, which can be given and which has shown complete pathological
If
response.
you have a metastatic disease, there are some other therapy. In addition to chemotherapy, you can go for some more analysis of the tumor, and you can offer some biological treatment, which are very
Can you
effective in.
offer, when you had sent the histology, could you study something more if you are coming there? What about the KRAS mutation or other mutation? Would they help you in taking a call?
So if there are a certain mutation, I'm not sure of the exact answer, but if there are certain mutations, cetuximab is also used as a monoclonal.
You mean targeted therapy? The answer
targeted therapy.
to the very good question that was asked was, in no metastatic setting, you talk about cure, but you treat with curative intent. There's a slight difference. Please understand. Your intention is that, but the fact that it's a metastatic disease, you don't talk in terms of cure. That is why I withdrew the word neoadjuvant from there. It will be primary chemotherapy, systemic therapy as you call it. And then you try to go for a salvage surgery, which could be synchronous resection or just the primary being treated. These patients can be observed. There are many patients where you do the primary, you remove the primary and you observe the metastasis over a period of time. Patients respond to chemotherapy subsequently. So there are various permutation combinations, and they found no advantage of doing, if you do both simultaneously, you need to have a very good performance status of the patient, and the patient should be able to withstand both the surgeries. The outcome depends on many factors, not just the primary in that case. Then, of course, there are various methods of treating, including the targeted therapy, where you do these KRAS mutation, and then you have the ones with or without that mutation. For the ones without, you can give the targeted therapy that will do they have a good response. Or otherwise, also the therapy changes there. This kind of a patient requires a good discussion in the MDT. Right? And what about the radiation therapy,
Yes,
which you mentioned, chemoradiation? You read about it, sequencing.
so usually,
yeah.
If you give neoadjuvant setting, what are the regimes for giving radiation?
so there is short course and long course regime, but a short course is preferred. You can also to help to spare other organs, we can also give brachytherapy or contact radiation.
Good. That's nicely answered. I think you've done well and you've read your subject well, but there are a few things here and there that I thought I'll add up. So I hope you enjoyed your presentation as much as we enjoyed.
Very well.
Yes, sir.
Very good.
Thank you, sir.
So can we close there, Dr.?
Yes, sir. Yes. Thank you, sir. She has answered well and good discussion.
Okay. Good night from US.
Good night.
Thank you,
Thank
sir.
you, sir. Thank you, sir.
Thank you, sir. Take care.
Thank you.
Bye-bye.